Good afternoon, everyone. I'm delighted to welcome you to this ASMEBITESIZE event. As you know, this afternoon's focus is on a research paper award winner, Dr. Hannah Gillespie, who's here with us now. And Hannah's going to tell us about how tomorrow's doctors can be more caring based on her phenomenological study. So this afternoon, we'll introduce ourselves as panelists. Then Hannah is going to give you a short presentation. After Hannah's presentation, we'll open up to the audience questions. We would like you to use the chat function for the questions. And if you use the function where it says open to panelists and all attendees, it means the rest of the audience can see the questions as well. So Hannah's going to present for about 20 minutes, then we'll have a really good question and answer session. The session is being recorded, so I'll just make you aware of that, and it will be saved and uploaded to the website afterwards. So I haven't introduced myself yet. I'm Anne-Marie Reid, and I'm a member of the ASME Educational Research Committee, and I chair the Researching Methodologies group. So Hannah was one of our award winners from 2019, Hannah, is that correct? Yeah. Hannah is here today with her supervisor. Many of you will know Professor Tim Dornan, who is a Professor of Medical Education at Queen's University in Belfast. And you'll hear some messages from Tim later as well. I'm sure he will be contributing to the discussion. So before more ado, I'm going to pass you to Hannah, and she's going to introduce herself to you properly. And then we'll look forward to some discussion. I'll pass to you, Hannah.
Thank you, Anne-Marie. So welcome everyone, and thank you for joining us this afternoon. My name's Hannah Gillespie, and I have just finished foundation training here in Northern Ireland, and I'm taking some time out of training to do a PhD in medical education. But today I'm going to talk about some research which I started as an undergraduate medical student whilst I was intercating at Queen's, called How Can Tomorrow's Doctors Be More Caring? And I'm going to start by asking a really simple question. What does it mean to be caring? And that's a simple question, but it's really hard to give a simple answer to that question. It's easy to know when someone's caring. That's the easy bit. It's even easier to know when someone's not caring. But to put into words exactly what makes that experience so is really quite difficult. Sometimes we use other words. We use empathy, sympathy, compassion. And these are certainly the words that dominated when I was a student. These are the words I read about in textbooks. These are the words I was taught in communication skills. And these are the words that we were warned would appear on OSCE mark schemes. But alone or together, they don't seem to really describe what caring is. And that leads into the background of this study, which started with a scoping review in 2018. And what we found out of quite literally thousands of papers on the topic of caring, a handful were from patients' views, which led us to conclude that patients have a minority voice in a research landscape that's very much dominated by authority and expert opinion. And at the same time, caring has many possible meanings in interprofessional practice. Very often when we sought to define caring, people looked in specific settings, specific specialities, and specific providers of care. And on the background of this ambiguity, over the last few years, doctors' ability to care has become a required and measured outcome of education. I'm sure many of you here will be familiar with GMC outcomes for graduates, which is a pretty definitive guide of what students need to know and do at the point of qualification. And it starts with the words, medical students are tomorrow's doctors. In line with good medical practice, newly qualified doctors must make the care of patients their first concern. And we felt that if caring was given such a large focus in medical education, we needed to think about what it was and who should define it. So we felt that greater clarity about how patients experience care could enhance patient-centred health professions education. Our aim in this work was to give patients a live voice in education for caring. And we set out to answer the question, how do patients experience doctors being caring or uncaring. The methodology we'll talk a little bit more about in the question and answer session, but was phenomenology, and specifically interpretive phenomenology. Phenomenology is very much the study of phenomenon or experience, and it does that by bringing phenomena to presence. Importantly, it embraces the intersubjectivity of researchers, and the research team was comprised of myself as a medical student, Tim as a consultant and medical education researcher, and also 3 general practitioners in both the UK and Canada who also had roles within universities. We were joined by Nigel King, an expert phenomenologist. So bringing our own experiences to the research was very important. We conducted the study in a primary care setting here in Belfast, and our inclusion criteria were deliberately broad. We wanted to find out about caring from a wide range of experiences, be they good or bad. And that's why we situated the study in primary care, because patients in primary care very often also have experiences of secondary or tertiary care. Our sampling was purposefully broad as well, and we sought to explore patients' experiences who had a wide range of experiences. And we've done that with the help of 2 GPs who knew their patients well. And ultimately, we've recruited 10 participants, 5 male and 5 female. And then we got into a bit of bother, because phenomenology is all about exploring people's lived experience. But as we started this presentation, it's really hard to actually describe what made those experiences so. People's experiences aren't always accessible to conscious reflection. And to try and get over this, we tried to use Pictor, which is a participant-generated graphical representation of experience. And over the next few slides, I'm going to show you how interviewing with Pictor worked. So our first question for participants was, could they recall an experience of caring? And this could be any experience, be it good or bad, from any point of time, so long as it was memorable. I then asked them to identify all the contributing factors, be they individuals, teams, places, anything at all that made that experience significant for them, and to write them on an individual post-it. The final task was to arrange those arrows to make sense of the experience. And participants could arrange them around the central experience using direction and positioning to indicate relationships between the arrows and between the arrows and the central experience. And this is what a completed Pictor chart looks like. So this is a Pictor chart from a participant in his 50s who talked about his diagnosis of testicular cancer. And that's the central experience. The Pictor charts themselves aren't that interesting, but what's interesting is how we use them. So instead of starting the interview with a set list of questions, we started by creating the chart and then used the chart as the interview guide. So I would have asked participants about the central experience. Well, what was it and what made it important and why did you choose it? And then we would have went through each of the post-its in turn. So talking about each of the factors. So we would have, in this case, asked about, well, what do you mean by advice? And what did comfort mean to you? And how did that come about? We then would have talked about the directionality and positioning of the arrows. So as you can see here, work is in the opposite direction of all the other more positive arrows. And then we would have asked about relationships between them. Were any particularly important? Were there any that were missing? And was there anything that they would then add? So in a sense, this was an interview, a really rich qualitative interview that was almost entirely generated from patients' experiences rather than a preset questionnaire. We then transcribed the results of our interviews and conducted a template analysis. This looks like a very linear process, but that wasn't quite how it worked out. So we started off with some open coding, looking for emerging themes, and formed a preliminary template. We then started a circular process of applying that to the data, refining the template, applying it back to the data over and over again until we got a final template. And using phenomenology, it was really important to move back and forth between patients' experiences or the data set and our interpretation, making sure that what we were doing still rang very true to what patients had told us. Again, in line with phenomenology, we carried out reflexive discussions between the research team, and it was supervised by Nigel King, an expert phenomenologist, as mentioned earlier. So in terms of results, just like the very purpose of this study, I'm going to go back and use patients' words to describe the findings of the study and to describe what caring is. So our overarching theme was that caring was genuine. Caring was above all genuine. It was when your heart is in it. It doesn't need to be a serious issue. It's that they take you seriously. Caring was not the cliched, oh, there, you'll be all right. It was real empathy, real engagement with an individual on their level. Caring doctors didn't even have to think about going the extra mile. It just comes natural to them. And being knowledgeable contributed to genuine caring. It's their knowledge. They've studied this to get their knowledge to care for you. Knowing that knowledge alone makes you caring. Being genuine and genuinely caring had three distinct facets. It was about individuality, engagement, and little things that went above and beyond. And I'm going to explore each of those in turn. So genuine caring was about individuality, and genuinely caring doctors seeing patients as people rather than diseases or numbers. It's just that he really, really knows what's going on with me. He knows everything about it, the illness, but he also knows about me. And they treated each patient separately, each person as an individual. It's about assessing the individual. It's more important to engage with the individual, every individual, and recognize that every individual is completely different. Caring doctors also engaged with their patients. They formed relationships with them. It was the fact that he interacted with me at my level. He treated me like a sentient, sensible, intelligent woman. He wasn't dismissive, he was engaged. And very often these relationships lasted over a long period of time and also involved relationships with their family. It's that they still take an interest in me 12 years later. That's just one really good experience of caring. And how long? It still continues. Finally, caring doctors done little things that went above and beyond. Caring wasn't a grand gesture that made a difference. It was as simple as introducing yourself. He got up, shook my hand, welcomed me in, and made me feel at ease. That's the difference. From when you walk in, you know that someone's going to care for you. And sometimes doctors done things that did go somewhat beyond the call of duty. And this is a lady talking about a phone call that she'd received over 20 years before the interview. For a doctor to phone you at tea time, that's what struck me. Doctors don't normally take the time to do that. So if we now go back to our first question of what does it mean to be caring? Well, it's more than compassion, it's more than empathy, and it's more than sympathy. It's about being genuine, engaging with people, treating patients as individuals, and doing little things that go above and beyond. So what did we learn? We learned that caring is at once complex and simple. It's complex because it defies definition. And it's simple, but small things like introducing yourself, greeting a patient, make the difference. This study also gives methodological insights. It shows how interpretive phenomenology can give patients a voice in education research, but also in other types of research. And it also shows how a rigorous methodology can be used throughout the research journey, from constructing a research question, conducting interviews, conducting analysis, and also presenting the results. We also have some educational implications, which we hope will be the focus of discussion. But really, in terms of the top 3 educational implications from this paper, we have that students should be encouraged to develop caring relationships alongside clinical competence. And that's a little bit different to communication skills training, which often comprises of short, time-bound interactions, very often with simulated patients. Our second implication recognises or comes from the belief that most people start medical school and join the profession because they want to care for people. And our second implication is that training and testing the relational skills of the small minority of non-genuine students is likely fruitless, and perhaps our focus should be on encouraging the majority of genuinely caring individuals joining our programs. The third implication is really for educators, and it refers to the training and assessment throughout your medical school. And it asks, are we as educators promoting students to demonstrate caring acts rather than become genuinely caring professionals? So to conclude, Coupling technical proficiency with human qualities, being empathic and respectful, genuinely, within doctor-patient relationships is the essence of caring. And neither competence nor caring is alone sufficient. Both are necessary, and integrating the two into a genuinely caring identity should be every student doctor's aspiration. So that is this part of the presentation finished, and we'd now be very delighted to answer some questions.
Thank you very much for that, Hannah. But what struck me immediately was how beautifully you encapsulated such an in-depth and lengthy and valuable study in such a clear way. So thank you very much for that. So if I can just remind the audience, you can now put your questions or comments on the chat, please, for Hannah, and make sure that you make them open to the panelists and everyone so everyone can see them. I'm just going to start off, Hannah, with a question I had. This is quite a complex study design. It's quite a novel one as well, and I wondered if you could talk a bit more about the decisions that you made in finalising the design when you were thinking about methodology. What sort of decisions did you make along the way?
Yeah, so we set out with the intention to explore patients' views, and in that way, that understanding experience phenomenology was almost an immediate choice. In terms of then bringing that into the research design, that is when we came, that's when we moved towards picture and to using pictures and using graphical techniques to really help participants reflect and explore those interactions that sometimes we don't always think about in real life, and we certainly don't think about them immediately. So that was probably the first step. And then also we made a conscious decision in terms of presenting the results, that we very much wanted them to come directly from patients, and to really form the interpretation from patients' views themselves.
And what was the challenge in that? How did you feel confident that it was the patient's views, or what other challenges did you find with that approach?
Absolutely. Well, one of the things was that picture was actually very accessible, particularly for patients who were somewhat less vocal and didn't really want to talk that much. Picture allowed us to really explore those in a very gradual way by adding in things that were of interest to them. In terms of the analysis, we tried really hard to constantly go back to the transcripts themselves, so that with every iteration of analysis, we were going back to the transcripts to try and find out and to make sure, I suppose, that our interpretation was in line with what patients had told us, and that we weren't, I suppose, juxtaposing our own opinions on top of those. Yeah.
I can see other people have got questions around this as well. So we've got a couple of questions asking Hannah, how did the participants respond? Did they all respond positively to the use of picture? And what do you think are the pros and cons of picture versus maybe getting participants to do some diagram or drawing?
Yeah, absolutely. So no, not everyone responded positively to picture. One participant thought it was absolutely ridiculous, and that was fine. And in a way, we were able to do it just more gradually throughout the interview. So started by just asking her about what experiences she had had, and then suddenly the picture chart appeared. And we also had a patient who wasn't comfortable writing. So in that sense, I wrote the factors and then we placed them around. So those are, I suppose, two cons of the picture diagrams. For me, this was obviously, I was a medical student at the time, and this was my first foray into research. So to go in and have what could be an hour-long discussion with someone without any guide could actually be really quite difficult and really quite intimidating. So actually for me, knowing that there was going to be a guide that came up and there was going to be some way to structure the discussion was actually really, really helpful for me as a researcher. And I suppose the other good thing was that it gradually came about and it wasn't ever a fixed finished product. So that if someone wanted to add something to it at another point in time, that was absolutely doable and okay. And post-its are very movable and things like that. So I suppose that's some of the pros and some of the cons.
Yeah. Yeah, it sounds, yeah, I can see there's been a lot of thought gone into that, and I imagine you were learning along the way as well, Hannah, as you became a bit more. I'm just going to move on to another question, if that's all right. How do you think we best prepare our students to become caring in the context you described? Suzanne has asked this.
So I think one of the most fundamental ways that we can do this is to actually introduce students to real patients and allow them to learn in practice in such, so that students first of all get the opportunity to develop relationships with patients and to develop those over some periods of time. I suppose the second way is that we can positively role model this, and students come to attachment sometimes for very brief periods of time, but working with people who appreciate that this is important and that this is something positive to be role modelled, both in the way they treat patients and also in how they talk about it before and after consultations, can be very important.
Yeah, yes, definitely. I think we've all heard stories and observed that in practice, haven't we? Another interesting question from a member of the audience was around this idea of caring. Do you think it's a fluid characteristic? To what extent do you think people can be taught it, and it's part of their personality, their essence, and to what extent is it perhaps a bit more fluid?
I think it is quite a fluid thing that is ultimately built throughout a career in medicine, and that, like many other skills, they develop as people move on within their career. I think we recognise within this that very often the starting point is about being genuine, and if someone has a genuine motivation, then that's a pretty good place to start, and to build upon that as they go through a career in medicine. I'm not sure it can be taught, and I'm not sure it can be assessed. And I think that that's one of the important parts of this research, is that caring is a very complex thing that can be described and we can recognise it, and it can certainly be role modelled, but I'm not sure that it can be taught.
And someone else asked about selection processes for medical school. Do you think it's possible, Hannah, to be able to in some way perceive that it's at the time of recruitment to medicine, that the person either has this genuine caring personality at the time, or it's something which can be developed within them?
That's an interesting question, and something that we have been asked before. And I suppose it's interesting because very often at selection to medical school, we try and look for lots of things and lots of things that are important. And students are almost expected to write very complex descriptions of why they want to be a doctor. And sometimes that very genuine reason of, well, I want to help people, or I just want to help, can be almost dismissed at that application process, and they feel they need to validate it and do further things. And actually kind of recognizing that that very simple thing can be a positive motivator that can carry on throughout a career, and could be one important thing. But again, I'm not sure if you can put a tick box of things that are important to caring doctors and to expect a 16 or 17-year-old to fill those in.
Yeah, with limited life experience, it can be difficult to make any kind of judgment like that. I'm going to move on to a slightly different question, Hannah. Mikhail has asked about your sample. So you chose patients from 2 GP practices, and Mikhail has asked, do you think if you'd identified patients within secondary care that your findings might have been different?
So that's a really good question. So as I said, we chose primary care because we knew that patients very often have experiences of secondary and tertiary care. And out of our 10 participants, 5 of them actually described secondary and tertiary care wholly, and others also talked about that as a kind of add-on. So we got plenty of insight about secondary and tertiary care. And even though the study was conducted within GP practices and patients were recruited from GP, very often they talked about different experiences. And I suppose on the other side of that, I'm not sure, had we recruited in hospital, that people would have also talked about GP. their experiences of being cared for in primary care. So I think it was quite a good balance overall.
Yeah, yeah. It sounds as though it was. One of the questions I wanted to ask you, Hannah, about your participants, I noticed more of them were middle-aged or older. I think if you'd had younger participants, it would have made much difference to the kind of data you collected.
Yeah, absolutely. So that certainly is almost a limitation of the study. And when we had applied for ethical approval for the study, we had to conduct it within a healthcare setting. So we originally applied to interview patients in their own homes. And obviously conducting it in a GP practice limited us to patients who were in some ways available during the day. So available during that 9 to 5 working hours, which almost immediately put us into a less inclusive age bracket, so to speak. I think younger patients might have some different experiences, but overall, the experiences that patients told us were sometimes from earlier points in their life.
Yeah.
They were sometimes from when they were very young and were then reflecting back on it. And I suppose that was I suppose a benefit in some ways, but certainly interesting.
Yeah. I've just got to ask about, someone's asked as well, Hannah, about, do you know of any work about the profession promoting role modelling rather than formal teaching? And does it tie in with leadership responsibilities, being mindful that yesterday was World Values Day? So I think you can see what that question is getting at.
Yeah, absolutely. And I do think that actually having it almost explicitly stated that this is something that we value and this is something that's core to us as doctors and us as a profession is really important. I suppose that in terms of actually modelling it and role modelling it, there is work in terms of how we train students in practice and how identity formation comes from participation in practice, and that positive role modelling, engaging students in practice and enabling them to reflect on their real patient experiences does help and can help students construct the identity of a doctor. And I suppose that one of those identities is the ability to care.
Yeah. I'm going to bring Tim in here because he's left a message about some tweets which I don't have access to. So I wondered, Tim, if I could bring you in and you could give us the comments or questions from the tweets.
You're on mute, Tim.
Thank you. My apologies. When I said tweets, I meant some of the questions that are coming through in the chat. And I'm feeling very sorry for Hugh, who jumped in first with a great question and it scrolled way beyond his question. So he said, how would you change clinical placements in light of this work? Hannah, you've very recently been a student. You're now on the other side of the fence. What's your view about that?
Your role was to answer questions, Tim, not ask them.
I'm just passing it on to you.
So yeah, absolutely. I graduated 2 years ago, and being a student is a very recent experience. And I suppose that in terms of changing clinical placements, one aspect is actually involving students. So involving students in meaningful ways in the work of practice and allowing them to meet patients, not only in that sort of bedside teaching, 10 minutes to interview them in that kind of way. So getting to know patients over the course of your medical school journey, I suppose. I think the other thing which we've alluded to is positive role modelling from clinicians, be they F1s or consultants or somewhere in between, that those people recognise that this is important and that it's potentially as important as the things students are trying to get signed off in their logbook.
I've looked through the questions and it seems to me that there's a spectrum of possibilities. One is that people are born caring or born not caring, and we shouldn't let non-caring people into medicine. Another, I suppose at the other extreme, would be that everybody can, or the caring side of people can be brought out by medical education. And then there's a question from Suzanne who says, how do you think we best prepare our students to become caring in the context you describe, and how can that be sustained?
So I think one of the ways about promoting almost genuine caring is to think about where, as a educational body, we might promote non-genuine caring, and to perhaps think about OSCE tick boxes and where students might get a mark for saying, I'm so sorry, and how that might promote quite non-genuine motivations to express almost caring utterances. So I think that might be one way to look at it. I'm not sure if you have any more ideas, Tim.
It's no, I can't add anything to what you said. I just wanted to add one thing to the question just now about age, because we in our research group have troubled the assumption that children are minors and that they are passive participants in care. And Freddie Spire, who won the inaugural PhD studentship, is looking at how students can have more, ASME funded studentship is looking at how children can have more agency in educational processes. And Gail, who asked one of the questions we've just heard, is looking at phenomenologically how children experience caring in the rather more complex situation where the parent is the legal guardian for the child. So in a sense, that's a work in progress. There's a methodological question from Susan, which I think it would be helpful if you answer. Let me see if I can get it. So I'll read Susan's question out. It says, regarding interpretation of the data, you wrote you were encouraged to articulate your own experience as a medical student and to draw other teams' members' attention to issues of power and hierarchy. And the question then is, to what extent did those aspects feed into your interpretation, which I suppose raises the broader question of bias and subjectivity in phenomenological research. Could you comment on that?
So as I said in the presentation, so the team was comprised of myself. I was a medical student at the time, doing an intercalated degree, Tim, and then Jerry Gormley and Drew Gilliland, 2 GPs in Belfast, and Martina Kelly, a GP in Canada, along with Nigel King, who's based in England. So there were diverse experiences of clinical practice within the group, and we were encouraged to, we encouraged ourselves throughout the process to really recognise when we were adding on our own interpretations rather than listening to what the data was telling us ourselves. And one of the things that we done was almost continuously went through the data under a template over and over again, making sure that what we were interpreting was very true to what the data set was telling us. And so that kind of constant comparison going through both of those was very important. I suppose the line that I think Susan was referring to is about challenging power dynamics within the research group. And I suppose that that's a conscious effort from everyone within the research group, one, to make sure that people are comfortable challenging other people's interpretations, which wasn't a problem, and also that there wasn't a dominant voice throughout the interpretation, would be my answer to that.
It's actually a great question about power, because people who have seniority and have expertise can be in quite a difficult position, because on the one hand you want that resource to be available if it's useful, but on the other hand you absolutely don't want that to stop a group being creative. And I must say, if I've learned one thing from my research career, it's that medical students very quickly make absolutely fantastic researchers because their minds are relatively uncontaminated at that stage. But I was going to just suggest, Anne-Marie, I'm sorry, I've rather subverted your role and I'll pass back to you, but I thought we might just ask Hannah, what does it take to be a good phenomenological researcher?
I think that leads on to what you've just said about medical students, in that they're somewhat uncontaminated, and actually just being able to go in and have a conversation with someone and really trying to listen to what they're saying is probably the most important thing. So being able to listen to what your participant is telling you and not try and direct the conversation beyond that, but really let it be a participant-led process. And then I suppose, being throughout the interpretation as well, really trying to focus on what patients or participants are telling you and what the data is telling you, rather than what you would like it to tell you or where you would like it to lead you.
Yeah.
I mean, my personal experience is that medical students, for example, intercalating, make absolutely fantastic qualitative researchers and will take to open interviewing and things like that like a duck to water, because they're taught that in communication skills. And we've found that within 2 or 3 days, medical students can start doing very sophisticated discourse analysis and so on. So if we do exercise too much power and hierarchy, my goodness, what an asset we lose. Anyway, back to you, Anne-Marie.
I was just going to say, I completely agree with you, Tim. Our intercalated students do some wonderful work, and as you say, they come with fresh eyes and enthusiasm and real interest. But I just wanted to move on to another question. Colin has sent in a really interesting question. He says, I'm fascinated by the parallels between your findings and the work of Michael West on compassionate leadership. I was wondering whether we could get the same conclusions if we surveyed health professionals.
So I think that's an interesting question. And I think compassionate leadership and the environment that we all work in is undoubtedly an important factor. And a very burnt out individual who's worked for 12 or 13 days in a row might lose some of that genuine motivation to care, even intermittently. Regarding asking health professionals, I suppose that there's a lot of research, over 1,000 papers from health professionals' experience or health professionals' definition or description of caring. And when we conducted our scoping review, out of over 1,000 papers on caring, there were 45 or 46 that had actually tried to elicit patients' views at all. I feel quite strongly that sometimes the experts in certain things aren't necessarily the experts. And in this case, understanding what was important to patients was really important. And certainly what health professionals, they might have different conclusions, but from presenting this work to groups of health professionals and educators, it's found that these answers have rang true to them as well, and that they can recognize it as much. They can recognize the validity of that and what patients have told us.
Yeah.
Kim, yeah, that's anything else on?
That's really important. I was just reflecting on the fact, Hannah, that we have quite an international audience, and so the findings from your study. What do you have any thoughts around whether there may be cultural factors? Might the findings have been different in different contexts, from your understanding?
Yeah, I think that undoubtedly that is a risk of the research. And Belfast is quite a small community as well, not the most metropolitan city. But I think that some of the things are very much about humane interactions and about being genuine. Being genuine is being genuine. And I suppose being individual and individual in your approach are one of those things that are likely welcomed by everybody. And I suppose other research will be very interesting in how it maps out across the world. That was part of the scoping review, which took a very global approach to caring and looking at multiple professions and multiple places of care. And its findings actually very much ring true with the findings of the Picture study, which I suppose is a reassuring factor.
Yeah, and from the way you describe it and the way you write about it, the caring is very much about the relationship, isn't it? But I was also wondering perhaps about patient expectations. From my experience, the patient expectations may differ according to country, culture, context.
Yeah, absolutely. And I suppose that we didn't explore that within this piece. Looking at the research as a whole, I think that distilling it down to being individual and being genuine are quite good, almost benchmarkers.
Yeah.
Multiple contexts.
And I think Colin, just to follow up on his question, has made the point that compassion fatigue may defeat ability to care, especially during something like the COVID crisis. Any thoughts on that, Hannah?
Yeah, well, I think that COVID has created lots of changes in healthcare. And I suppose it's changed fundamentally how we even interact with patients in terms of what we wear and how potentially close we come and all of that. And has also changed about healthcare teams and who's going in to see an individual patient. Is it now one person or is it the entire ward round? So I suppose it has changed lots of things about how we deliver care. And some of that is about potentially being more aware of how patients are experiencing that interaction. So I'm sure it's absolutely terrifying to have people coming in lots of different gear.
Could I just pick up on that point? Because I think we've got to be very careful not to look at the issue too simplistically, because it may imply that you have a finite capacity to be caring, and once your capacity is exhausted, then you get compassion fatigue. But of course, there are many more factors operating than that. And it's actually a balance between, if you like, the personal demands on you and the rewards you get from it. And I think one of the real problems with compassion fatigue is the difficulty of being genuinely caring when, for example, you're afraid all the time you may be blamed for making an error, or what you've done may be found wanting. So I think that, of course, we have to learn coping skills. And in fact, one of the things that's come out of the work Hannah and I have been involved with is that self-management is one of the most important capabilities that we do not give medical students. We don't help them develop that, but self-management's the most important thing. So that it's a matter of exercising compassion within a broader package of self-management, but frankly, being allowed to get on and do it without too much outside interference, I think, is very important too.
Yeah, and that links to what Susan has asked as well. And she said, in striving to make doctors more caring, may they become less resilient, or is it more likely that we will make them stronger?
That's an interesting question. I suppose that one of the things that we thought about during this research was that most people enter medicine with a genuine motivation to care, and doing something and practicing in a way that aligns with your values is likely to be a fulfilling thing that will propel you in your career. And I suppose that sometimes those systemic issues which make that harder and which make it more challenging to work in can reduce that. Would be my thoughts on it.
Yeah, and I think there's a danger as well of thinking of resilience as too much at an individual level, because it's very often, isn't it, the person within the context of those relationships and the structures around them. And maybe to some extent, caring is similar as well. And if we look at issues like the mid-staffs inquiry in the UK, where there were real failures of caring, the culture is very much influencing the way that people behave.
Yeah.
Could I just add in just a reference to some work which is coming through at the moment, which you asked Anne-Marie about cross-cultural factors. And Hiroshi Nishigori in Japan, I've been working with him, and he's done very, very interesting work looking at, in the context of a Confucian culture, how the balance of reward and benefit plays out, and the different ways in which it does so from the Judeo-Christian cultures of the West, and the way those things contribute to burnout. He's completing a PhD in Maastricht University, and has published some beautiful papers on that. And he's particularly looked at the way cultural values from the Japanese actual samurai tradition translate into contemporary professionalism. So I think it's great that you, Anne-Marie, that you encouraged us to think globally rather than nationally.
That sounds as though it's definitely worth looking at that reference, Tim, so we can perhaps add that to the end of the presentation as well. What I did want to ask Hannah about the next steps before we start to round off. So you've done some fantastic work here, and obviously ably supported by Tim and the rest of the team. What's your next steps in terms of research?
Yeah, so I'm at an exciting point, just submitting a proposal for a PhD in medical education in Maastricht, which is a very exciting time. And I suppose going forward, my work isn't so much directly linked to this, but certainly follows on to the theme of medical students learning from real patients. So my PhD research is about how we can prepare students and what is preparedness and what is readiness for practice, and how we might encourage that by enabling students to learn from real patients. So we're planning some studies in terms of implementation research and changing how we might educate students and to see how that makes a difference in their undergraduate training.
Well, I really look forward to that, and I'm going to ask Tim as well at this point. I'm quite interested, Tim, in the extent to which you think Hannah's work has had any influence in medical education in Northern Ireland.
I actually think her impact has been quite broad, and I think it gives a very interesting insight into medical education research, because there is a sort of model that you do research, you publish it, the publication has impact, and the better the published research, the more impact it has. In fact, what Hannah has done is to speak directly to the soul of the medical profession. And that she's simply presented, well, I say simply, it's far from simple, but she's presented in a very accessible way what for highly motivated doctors is the essence of what they do, what they'd like to do, why they're doing it. And I think that just to put it out there and legitimate that which doctors know to be true is very, very important. And I think that the social media and other response, the general response to her work's been very, very high. And of course, it's beautiful work, but it's also reflexively striking a chord. And I think that's one of the really important things we do as researchers, is to strike a chord with people who just need to be told it's okay to do what they intuitively do.
Yeah. I totally agree with you. When I first heard Hannah, that was exactly what struck me, and it made me think of that concept of genuineness, not just in terms of doctors, but in the wider world in terms of leadership. We have leaders, we have colleagues who are genuine, and others that we feel perhaps aren't so genuine, and actually being able to pin it down is tricky, but we know it when we see it and when we hear it. I'm going to round off there. While the chat's been carrying on, Hannah, there have been some fantastic comments on your work, really applauding what you've done, and a lot of people have said how much they've enjoyed it. And Colin Melville has said, maybe we can get Hannah to come and share the work with my GMC colleagues. It's insightful, important findings, and we need to incorporate them into our thinking about the future and purpose of medical education and relationships with parents. And I think we would we'd all agree with that. So I would really like to thank you, Hannah, for coming and presenting today at the Bite Size, and of course to Tim as well as your supervisor. I think it's led to some really interesting discussion. It will all be captured on video, and it will be uploaded to the ASME site in a few days. I'd like to also say thank you very much to our audience. Your contributions, your questions have been very stimulating and very insightful as well. I will apologise if I've missed questions. They were scrolling through quite quickly. I know Tim managed to pick some of them up. Any questions that we've missed, Hannah will take those afterwards, and we'll post the answers up as well as part of the video posting. So I will I'll just round off there, but before I go, Lee has asked me to remind you there's another ASME Bite Size session on the 29th of October at 1 o'clock, and it's Dr. Jane Garner and Ed Horowitz from Edge Hill, and they're looking at providing virtual support for medical students. So thank you again, Hannah, for an excellent presentation, and Tim and Jenny and Lee. And I hope you all have a fantastic weekend, and we'll look forward to seeing you at another event.
Thank you so much, Anne-Marie.
You're welcome. Bye for now.